Our next session is, again, to continuation of what we've been talking about a little bit earlier about kind of simulation. We have Noran Nadir and Andrew Vincent from UIC Peoria talking about simulation and specifically its incorporation in undergraduate medical education and working with medical students.
Hi, everybody. Thank you for having me back. I'm the director for simulation at Peoria, Illinois, and JUMP Simulation Center. I used to be the medical education director for a couple of years there. Then I transitioned over to my role. I just want to hand off to my colleague, Dr. Vincent, and I'll be back shortly.
Hello, everyone. Thanks for coming. I know the beach and the pool are enticing this time of day, so we appreciate you being here, sticking around. So today we're just going to talk a little bit about sim and where it may fit in your undergraduate medical education. I'm the director of medical student education at UEComp and M4 clerkship director, so I have a little experience with kind of both M3 and M4 students and using sim as part of what we do. I have no financial disclosures. Rand doesn't either. So as far as the objectives today, we're going to talk a little bit more, understanding a little bit more about simulation learning and how it can be applied to the EM clerkship. Practice kind of putting a sim together, giving you kind of a template or a form to use to do that if you don't have one. Talk a little bit about debriefing and then also learn how to use simulation for assessment purposes if that's something that you desire, if there's a place for that in your curriculum as well. So we'll begin by obviously talking about the kind of overview of sim, some of the background of sim, and then the design, assessment, debriefing, and then maybe where sim fits in your UGME. So when I think of sim, I mean, my first experience with sim was as a resident, and so for me, it's always been this thought of kind of correlating high fidelity simulator cases with that's what sim is. And really, like, sim takes on a lot of different forms and fashions, whether you're like full on board believer or advocate of sim, or maybe you're a little more skeptical about its role and maybe some of its limitations. You know, really sim is all around us in many different ways, whether that's the OSCE with the standardized patient encounter or disaster drills, procedure training. It's kind of everywhere. And so you've all probably been exposed to it on some front. To sim or not to sim, so this is where you start to ask yourself, you know, is there value for this in my curriculum and what I'm doing? Or is it not really for me? It's not for us. I'm not trained to do this. And, you know, I would advocate for sim in the setting of how our world has changed a lot. I mean, many of you are, you know, right on that forefront of the interface between outpatient and inpatient treatment, and obviously there are multiple forces at work that are pushing us to care for our patients in the outpatient setting and not so much in the inpatient. So the see one, do one, teach one model is kind of a thing of the past. We've got this really, you know, driven society where we're really driven more towards quality and less towards like this to err as human idea. So with that, it's great to have a way that you can teach your students and residents in a low stress, low fidelity, low impact environment where it's safe and they can be kind of protected and the patients are safe too. So I think that's really where sim has a real role in our teaching. As far as like making it successful, if you look at this study by Eisenberg, number of great points here in regard to like how you make sim be successful for what it is that you're doing. I think a couple that are worth kind of mentioning here are super important that it's an integrated part of your entire curriculum. It's not just a standalone event. It's not something you just do, or, you know, it's that one thing that we go do each month. It's got to be integrated into the curriculum. We pay special attention to making sure that if we're doing a sim, that there's either some small group breakout session that pertains to that, or maybe there was a lecture the same day or a week earlier on, you know, something cardiac before we go in and do this kind of cardiac-based sim. I think it's really important that it totally fits into your big picture, not a standalone event. It's also great in the sense that, you know, all of our residents and students have different varying experiences, and this is a way to really kind of standardize the experience that they have. You know, we all know the white cloud resident or the black cloud resident who says, well, I've never done that, or I've never seen that, and when you use sim, you really have the ability to kind of have control of that and make sure that they all get kind of a standardized exposure.
All right, so I'm going to speak about sim instructional design, and I really like talking about this because, you know, all of us are educators, but we're also asked to produce scholarly works. And I think from the framework of scholarship, it's really useful to have a deliberate approach to having any kind of simulation curriculum. And I promise I'm going to make it not very cerebral. So I'd like to think of any kind of simulation activity or curriculum in a very simple way, 3 questions. Where are we going, which is sort of the performance of my analysis. And here I just really want to know what my context is. I'd like to know who my learners are and what tasks I need to perform. Then I go into the second question, which is basically, how do I get here? How do I get there? Here's where I develop my strategy. And then finally, my evaluation part. How do I know that I'm here already? So these are really important questions when you're thinking about creating a sim curriculum or sim activity. So I'm sure most of you are probably familiar with Kern's 6-step approach. I really like this approach, again, for the same reason that it allows you a deliberate way of planning your activities so you can really reap the benefits of actually scholarship. Now, if I were to spend a whole lecture on each of these 6 steps, I'd probably be here for 6 hours. I'm not going to do that. I'm going to kind of briefly go over it. But suffice it to say that you can probably develop scholarship pretty much at each one of these junctures, okay? The first step, problem identification, is usually something that makes itself apparent to you as an educator. It's going to be your medical student education director who's going to come to you, or the dean of the school who's going to say, well, there's a deficit, we notice it, do you think you can help us out? Sometimes your in-training exam scores, such as your shelf exam scores or your SEM clerkship scores, will also point this direction. The next step would be a needs assessment, and here you really have to ask, are your educational goals being met, and if there are any kind of learning skills or knowledge deficits, gaps. And if so, are these amenable to simulation? If the answer is yes, you move on. If it's no, then you figure out a different strategy. If you are pursuing a simulation course, you come up with SMART objectives, which are essentially very specific, learner-centric, and I encourage everybody to have a broad domains in terms of how you're going to structure your objectives. I don't like to focus solely on knowledge. I think we get enough of that through didactics, lectures. I like to include psychomotor and affective and attitudinal domains as well for my objectives. The next step is educational strategy, which is very important because SIM is not a sort of all-encompassing entity. It actually works best when it's integrated with other things. So if you actually create a pre-learning or a post-learning piece for your SIM activity, it actually really makes it a robust learning experience for your learners, especially students. I love the CDEM curriculum repository of cases, and I always use this as my pre-learning. The other one is EM Basics for pre and post as well. The next step would be the implementation phase. Now, this is where things get challenging. You need to know what your capabilities are. If you are operating in a basement with a single mannequin, which I did for a huge portion of my fellowship, and you're the only person who's programmed the mannequin, you need to know that so that you can learn how to do it. That may totally dissuade you from doing SIM in the first place. But if you have the ability to go and program, or you have somebody who's able to help you out, you have a SIM tech, sit them down, have a conversation. What do you have available? What kind of mannequins are there? What kind of task trainers are there? Those are pertinent questions with respect to what you're going to plan ahead. The other aspect of this is costs. Do you get protected time to do this simulation? Is there a way to buy down your time? Okay, is there any cost involved with using the Sim Center? Who is paying for this? Is the medical school paying for this? Are you just kind of creating it out of the fly? Do they let you use it for free? These are very legitimate questions to ask. And finally, do you need any standardized patients or confederates? Do you pay for that time, or they just volunteer that time? These are very important questions to ask. Now, evaluation is probably the one component of SIM that sometimes gets looked over. We all like to SIM, we all debrief, and then we just forget about the evaluation component. I propose to you to actually try to have some kind of evaluation checklist, and always have some kind of evaluation of the actual simulated case so that you get feedback about what you're doing, whether it's effective or not. Say you do a very fancy, very expensive SIM, and at the end of the day, the students hate it, but there's no way for you to know that. You're going to keep repeating the same SIM over and over again without having that valuable feedback. It's going to be a little bit concerning. And eventually, the outcomes. What impact is your SIM curriculum having? And it's a really hard thing to think about students, but really, you're planning out their outcome from M3 year, which is when they get clinical, all the way out to when they're practicing attendings. So if you think about it in a deliberate way, chances are you're probably going to get some scholarly projects out and possibly published. Keep doing this the wrong way. Okay. All right, so I propose to create a little bit of an exercise. It's a little bit of an interactive session. You can stop me if you like at any time. You can pick any of these cases. I'm going to pick choice of hypertensive patient, basically. And just to remind everybody that I have included some resources for this particular lecture in electronic resources available, where there's a template that you can follow along with. If you don't want to do that, you can review it in your free time. And there's also some other resources, just in case you just want to know how to get SIM cases. There are pre-published SIM cases. You can do that as well. But operating under the premise that you want to know how to actually create a SIM case, the way I go about doing it is I usually pick a broad topic, such as a hypertensive patient, and then I kind of go ahead and try to decide, what experience or what cases have I experienced personally that particularly resonated, which would be robust cases for a simulation activity. And then how can I create this into a case? And so usually I come up with quite a few examples. And just to kind of adopt a very systematic approach to doing this, of course, you have to identify your learners. For me, I work with M1, M2, M3, M4 students as well as residents, so my intended learners are very important. And as you'll see when we talk about debriefing and evaluations later, that the way I create my case sometimes mirrors how or what level my learner is at. I come up with my session objectives. They're specific to the case. So in this case, the hypotensive trauma patient, for instance. I decide on my pre and post learning. I come up with a session description. The session description is a very important piece of document. It basically describes exactly what a simulation is going to be about. It will give you a brief HPI. It will give you the settings. For instance, you're doing it in a community hospital versus a level 1 trauma center. It will give you basic information about who the person is, where they were found, whether there's going to be paramedics who are going to bring them, they're going to be brought in by family, that kind of information. The other aspect of this is I really like using stimuli here. Well, by stimuli, I mean, for instance, if say you decide a case of a patient that you saw with Ludwig's angina, sometimes, you probably want to include that picture because you may not be able to simulate that identical sort of ambience. If you take a look at a mannequin, no matter how obstructed you make the airway, it won't quite look like a Ludwig's patient. So it's perfectly okay to have a picture of that available. At the same time, think ahead. Like, is there any kind of EKG finding or chest x-ray finding or labs that would make this case worthwhile? That would be important to include over here. I just make a PowerPoint of it, have it ready, and I just hand it to my SimTech. That's what I do. The next aspect of this is figuring out, do you want to do an in situ sim, which I think is all the rage now, especially for residents, but also medical students, and sometimes, especially on the floors, a lot of the times they're doing codes, and we'll see a situation a little bit later where we do, in fact, do something similar to that. The next aspect of this is the session scenario setup form. Some of you may have seen this already or some version of this. This basically breaks down how your case is going to progress. So you have to sit down, put your thinking hat on, and figure out, okay, what is my presenting state of patient going to be like? What are the vitals going to be like? What are they going to look like? What are the physical exam findings that can show up on my mannequin? And what are the actions that I desire my learner to know so that they can either get all of these actions or none of these actions to progress to the next stage? And then plan your next stage. Is it going to be worsening or deteriorating patient, or is it going to be improving patient? Again, a lot of this is dynamic, and it depends on how well your learner performs. But remember, this document is also very useful specifically for your SimTech, because he's the one who's going to be hopefully manning the mannequin. If it's you, then it's probably not so much of a problem because you can kind of change around the physical exam findings, the vitals on the fly. But if you have somebody else doing it, it's usually useful for them to kind of review this before you actually embark on the sim. Once you're within the sim and running the sim, there's going to be a dynamic interaction between you and the sim jockey. Okay, so what do we do next? From here, at this time, you also have to think about any kind of confederates or standardized patients that you might want to use within your sims. I love using standardized patient sims as opposed to plainly high fidelity patient simulators, specifically because you can get a lot more dynamic responses from standardized patients. It's very cool. You actually get to direct an entire little mini series of whatever show you're trying to perform. And the only problem with this is that you do have to create a script for them. That's basically your standardized patient guide. I like doing it. I was always in dramatics in undergrad and, even in medical school, believe it or not. So I like doing that part. Direction is awesome. And so I urge you to kind of create a standardized patient guide or confederate guide. And then another aspect of this is that if you're going to create the simulation for somebody else to run, you probably want to include a debriefing guide, a list of clinical pearls that could, stimulate your debriefing after the case is done, just so that whoever is running the case is not caught completely unawares. The debriefing guide is also going to include everything else that I've mentioned so far. The final aspect of the case, and some people do this, some people don't, is a performance checklist. And this here is a classic example. We kind of go through a primary survey, secondary survey, and for our patient was basically neurogenic shock patient in the hypotension. You kind of go critical actions that you think are significant. Now, if you're going to make this into a high-stakes kind of assessment tool, we're going to talk about that later, you probably need to get some kind of Delphi panel together, get some consensus and inter-rater reliability. But for most purposes, we don't really use it in that way. We just use this as a guide so that whoever is facilitating the debriefing can kind of go across a checklist and say you either did this or you didn't. We don't videotape our sessions yet, but that's something that is also available to you to go back for performance improvement. So this brings me to my second aspect of this case, which is simulation-based assessment. Simulation is awesome. It basically is able to let you kind of target tier 3, which is a shows how level of this pyramid, Miller's pyramid. And because of this, there's a huge amount of interest, and this is a hot topic. Simulation-based assessment is already happening. OSCEs are prime example. Step 2 CS is a prime example. That is actually simulation. And EM milestones seem to be very amenable to simulation. There's some studies out there that suggest that that's where we're heading. There's virtual simulations being used in our oral boards. So they're already here. There's a push from accreditation bodies to use simulation-based assessment and to standardize assessment. Before you jump and start using simulation for assessment, there's 2 questions you need to ask yourself. The first question is, what is the purpose of your assessment? Are you using assessment for learning, or are you using assessment of learning? The second question is, what are you going to do with the results of that assessment? Are you going to use those results to help your individual learner perform better, or are you going to use that result to promote them or pass or fail them? And this brings us to your summative formative assessment, which I'm sure everybody is aware of. Summative assessment, basically assessment of learning. It is infrequent. It's usually graded at the end of a semester, for instance. It's high stakes, anxiety-inducing, and it typically gives you a score or some kind of implicit feedback that the learner can take back with them. Formative assessment, on the other hand, is very frequent. It is basically assessment for learning purposes, for enhancing learning. It is separate from your grades. It is throughout your learning period. And it's very tailored to your individual learner. And the goal of this session is to improve the performance of the learner, not necessarily to promote them to the next level. If you are going to employ summative assessment, like I mentioned before, the performance checklist or global rating scale, it needs to be validated through a Delphi panel and rigorous psychometric testing. And that's what we do for some of our OSCEs right now. And certainly the Step 2 CS, they're all been pretty rigorously tested. I'd like to offer you a sort of a different approach to formative assessment, or what I call debriefing. Now, debriefing has been around for a long time. It has been used in the aviation industry very recently. It was originally developed in the military. And people kind of get very scared when they hear this term, but it's actually quite an interesting phenomena. The definition of debriefing at the very basic level is just it's a conversation. It's a conversation or dialogue, self-reflective activity to review a real or a simulated event, and for participants to kind of look in at their actions and think about it. So self-critique. Participants reflect on their thoughts and actions, and then they try to figure out how to improve it for future. And the objective of this is to really sustain or improve performance going forward. Usually, for a simulation purpose, a debriefing to be effective should be about 2 to 3 times the length. So if your sim case is about 7 to 8 minutes long, your debriefing should be about 21 to 24 minutes long. Not going to belabor this point, but debriefing is really based on principles of adult learning theory. Knowles Andragogy maintains that if you're an adult, the things that you will find interesting and motivating are things that they're going to make sense to you, is what's going to propel you to learn. In other words, if you find value in a topic, you're going to go look it up and you're going to find some way to learn it. I'll give you an example. I recently found out that ECMO is sometimes being performed in the emergency department to improve resuscitation. I think that is phenomenal. I'm super excited about it. I want to go learn more about it. That's an example of Knowles Andragogy. It's not required, but I want to do it anyway. Then Cole's experiential learning is also useful to explain some of the debriefing principles. People have concrete experiences. They will observe and reflect on those experiences. They will form some kind of abstract concept, and they'll test it out in the field. And this cycle will keep on repeating until you start refining your techniques. Then Mesereau's transformative learning is also applicable here. Here, we think about some kind of disorienting dilemma. For me, I had a patient with aortic dissection who basically died. I was a third-year resident. I totally did not know what was going on. The patient was an extremist, couldn't save him, figured out later after pathology reports that this guy had a dissection. Very disorienting, very demoralizing. Made me kind of step back and critically assess what I knew about aortic dissection and how it manifests and what did I miss in this patient. Went back to acquiring new knowledge, read up on it, took a couple of more courses specifically in stabilizing critical patients, and then went back to the field and applied it. And this kind of learning, everybody has experienced it, where there's something where you're like, oh, SHIT, whatever. I don't know what is going on here. And those kind of moments really make you question who you are, what did you do wrong, what do you not know? And then you go back in the field, you go back and learn. And that's very, very crucial to the basis of debriefing and learning. So when you think about formative assessment, and debriefing is formative assessment, you think about patients, learners, and you think about their frames, which are essentially preconceived notions. All of us have these. We use these frames, they're kind of a lens that we view the world through. And we actually act on these frames. So when you're simulating and you observe a particular action being performed, and there is a gap between that action being performed and what you actually desire, that's a performance gap. You actually have to go back and ask why the action happened in the first place. What kind of frames propel those actions? And if there is a gap between the desired action and the observed action, that gap can be the basis for providing feedback, figuring out why it happened and closing the gap. And that is what formative assessment or debriefing is all about. And how do you actually go about doing this? There are certain stages to this, and we'll go over this. We're going to go over 3 different models, and it's going to be interesting. So before we kind of delve any further, some things that are very, very crucial so that you do not get learners. Somebody asked a question in one of the earlier sessions about what do you do if you've got a distraught learner who just doesn't buy it? Well, you set the stage. You make sure that it's a psychologically safe stage. And what does that mean? It means that, say there's a learner who comes to my sim session and totally bombs. I don't go and tell Dr. Vincent here, who's the medical student education director, that student bombed. I don't go back to the dean of the medical school and say, hey, so-and-so student is terrible. You don't do that because that's violation of a safe space clause. Always bear the objectives in mind. Always be calm and collected. Exhibit genuine curiosity. And remember, your learners, all their actions are well-intentioned. Nobody goes in a sim session wanting to harm patients, okay? Everybody's doing what they think is best for the patient. And if they're doing something wrong or inappropriate, there is a genuine teaching opportunity there. So work on it. Use open-ended questions. Please do not use this as a personal venting space. I've seen that happen with a lot of faculty where they go and their frustrations from the clinical workplace make it into the debriefing. You start using it as a personal venting space. It's going to totally upend your simulation. Don't try to assign blame. Teach a student a lesson. Don't do that. Don't dive into a debrief if you're immediately upset about something. Say you got a really bad news, you're about to be fired or something, I don't know. Don't go in debrief at that time. It won't be an effective debriefing. Don't use guess what I'm thinking type questions, great questions. And these are very classic. I'm perfectly capable of doing this. I've done this. Example of this would be your student, you ask them to come up with a differential for 3 different things for chest pain, and the one thing that you're thinking of, they don't mention on those on 3 differentials. And so you keep asking them, well, what else is on the differential? That's a classic guess what I'm thinking question. Don't do it. It's pretty counterproductive. So in terms of the phases of debrief, how's everyone feeling? That's the first phase, the reactionary phase. Sims sometimes get to be very emotional periods. Learners come in and they become very kind of defensive. So it's very important to kind of diffuse that. And if you acknowledge that in the reactionary phase, you can kind of get past into an understanding or analysis phase. Here, there's different approaches, and we're going to talk about 3 of these, but plus delta, a little bit more, I'm going to get into it. What worked, what didn't work well, how can we improve? And the advocacy inquiry molecule that Harvard developed, I'll go into that a little bit more. And finally, the summary phase, what did you take from all of this? So the plus delta debriefing technique. Here, you basically go, what went well, what didn't work, what can you improve on? And the pros and cons of this model basically are that it's a brief generic model. It can be pretty much applicable to any situation. It focuses on observed actions. It's particularly useful if you're short on time. But it's very superficial. It does not really go into depth. So the mind frames behind the actions you don't really explore. So whether you can actually cause behavior change in this, we don't know. Advocacy inquiry was developed in Harvard Center for Medical Simulation. It's a much more widely accepted model. Here, the human behaviors which are based on pre-existing frameworks or assumptions are questioned, and this model is all about uncovering those assumptions. The pros and cons of this are that it is applicable in a one-to-one setting. It is applicable in a group setting. It does have a tendency to have somewhat of a behavioral impact. At least that's what the claim is. And there's less of a chance of a learner getting defensive. It's time intensive, so you have to be prepared to spend considerable time. In order to do this effectively, here's a cheat sheet for this. There's multiple ways of doing this, but this is how I do it. There's a script. The first line goes, I observed or noticed blank, which is an action. I would have done it differently according to XYZ guidelines. What are your thoughts on this? It's very simple. Sounds a little strange, but you practice a couple of times and you get it. And I'm going to hand off to Dr. Vincent to talk about the rapid cycling.
So rapid cycling is another means by which you can debrief. I don't know, anyone here ever done rapid cycle before? Is that something you're familiar with at all? It was developed at Johns Hopkins by Dr. Betsy Hunt, and what she kind of stumbled upon it with her experience with her pediatric residents and seeing that they were having a hard time taking their PALS training and then taking it to the bedside and actually applying it and doing it appropriately. What she saw was that they could all go through the mega code, they could all check all the boxes that need to be checked, and then when they got in real time, it seemed that there were these like almost predictable sticking points that kept happening in each case, where it was like, you've got this great like rock star third year resident and they don't initiate chest compressions. There's a verbalization of the patient doesn't have a pulse. They don't have a pulse. They don't have a pulse. And yet no one's doing chest compression. So from this, she said, I feel like we're doing all these simulations and we're finding that there's these obvious sticking points that keep coming up. So rapid cycle is a little different in that the approach is a little bit different, and obviously the goal, the endpoint is a little bit different as well. The idea being that you have very clear idea of what it is you want the learners to take with them when they go, and you have kind of an idea predictably where that might come from, and then you run the case again and again until everyone has got kind of a full grasp of what it is that what you set out for them to learn. It is a little bit different than other types of debriefing in sim, and so it's really important to let your learners know, hey, this is going to be a little bit different. There's going to be timeouts. I might come into the room and say, hey, timeout. We're going to start it over again. Here's what I observed. Let's go from the top. It's just really important, I think, for the safety of the learners and their psychology to say, you didn't screw up. You didn't ruin the case. The patient didn't die. I'm just stepping in so that we can review and reflect and get better at this skill. So I love this for really all levels of learners. I've used this for attending level learners and certainly for my M3s. I love it with M3s. Pros and cons, there's a knowledge reinforcement, which is a huge pro. It's very directive. I think one thing as a facilitator you also have to be very cognizant of is, we've all seen the sim that ends up going down like multiple rabbit holes, and you can get to all sorts of like fun destinations a lot of times with a sim. And with rapid cycle, you have to be very careful with that. You have to be very cognizant of how far off the path you're deviating and being willing to say, hey, everyone stop. We're not going to go there. If you want to talk more afterwards, please come see me. I'd love to talk with you. But today we're going to do chest compressions when the pulse goes away. So that's, as a facilitator, I think that's something that's a little bit different, but it can be super valuable to your learners. So now we're going to do just a little exercise here. I just want you to think to yourself or maybe jot down a few ideas as we kind of watch this M4 student do his thing here. He's going to be seeing a patient that just has here with some dyspnea. And I just want you to think as you watch this scenario, maybe what feedback you would give this student, maybe what type of debriefing style you think would be most appropriate for them. And hopefully you'll see that you could really go about this, multiple different ways. Got a few cat lovers out there, so we won't talk about different ways to skin a cat, but there's different ways to do it and get to the same endpoint. So see what you think.
Now, can't breathe. Can't breathe. All right, I'm gonna get the doctor in here, okay? Are you hurting anywhere? Can't breathe. Just. Okay. Need air.
Hey, I saw your light going out next door.
This is Mr. Jones just had surgery 2 days ago. Okay. Now he's complaining of some chest discomfort and some meters short of breath. When I looked at his vitals, he's got a tachy heart rate of 120. He originally was at 79% on-room air. Put him on 2 liters of oxygen. He's still starting to fall, and he's only down to 71.
Yeah, what kind of surgery?
He had a left femur fracture, so they did a fix it.
His leg's pretty swollen. I'm kind of worried about a PE here. I mean, we probably need heparin and stuff.
I have him on 2 liters right now, but his O2 sets are still falling.
Okay. Alright, sir.
Do I get the crunch card?
Yeah. Hi, sir. I'm gonna take a listen to you here, okay?
I can't breathe.
Okay.
Can't breathe.
Okay. Keep taking those deep breaths just like you are. I'm gonna give you a little more oxygen here. You're on 2 liters. I'm gonna turn you up to 4, okay? Okay, just keep breathing here. Yeah, I'm really worried about this PE. He's got leg swelling and he's hypoxic.
Well, his O2 sets are still falling.
Okay, I'm gonna give you a little more oxygen, sir, okay? I'm gonna turn you up to 6 liters here. Keep taking those deep breaths, okay?
Can't breathe.
I'm gonna listen again.
He's at 65 now.
Feeling dizzy.
Okay. Okay, I'm gonna turn him up a little more. I'm gonna give you 10 liters here, sir, alright?
He's on breathing with cannula too.
Okay. Sir, keep breathing nice and deep for me. So 10 liters.
Who do we need? Do we need anybody
I
else?
mean, I need,
Can't breathe.
Who do you want me to call?
I need like anesthesia or some, somebody to help here.
Well, they should be on their way, 'cause I just pressed that emergency button and he came in, so they're on their way.
Alright, so you're gonna be on 15 liters here, okay? I'm gonna listen again, okay?
So this time, the patient has lost consciousness.
You breathe nice and deep.
60%.
We can see the nurse is putting the bag valve mask and the airway kit right up there.
Sir?
He's not responding.
Sir? Okay, so he's breathing nice and deep.
What's going on?
I've got a gentleman here who's really hypoxic. I'm kind of worried about a PE here.
Is he awake? Does he have a pulse?
He's on 15 liters nasal cannula and he does have a pulse.
Is he awake, sir? Okay, why aren't we BDMing him? Let's start BDMing him.
Okay.
So probably a lot of things that run through your mind there as you're watching that. I wonder, just from the crowd, I mean, you can kind of just shout out. What might you see here or concern you? Would you stop this student somewhere midstream, or would you kind of let, as a facilitator, sometimes I find myself like agonizing on the other side of the glass, like, make it stop. Student needs what?
He needs a hug.
Yes, he does. He needs a huge hug.
Yeah. So, I mean, the whole reason for doing this is like, what would you guys use? Would you use advocacy inquiry or rapid cycling, or what would be your go-to debriefing technique for this kind of situation? And there's no right or wrong answers here. I'm just curious.
He needs a lot of support. I'd be trying to like pause.
Yeah.
Exactly.
In my experience, a lot of times, I mean, I think in general, it's great to have a good idea of how you're going to want to debrief a case before you start. And then something like this happens. And then you decide maybe we need to like change our plan almost midstream. So I think this is a good example of, maybe this is an M4 student and maybe something else, you maybe had a better idea of what you wanted to do with them. And then all of a sudden it becomes like, oh, this is kind of a crisis. We need to intervene.
You guys probably said this, but I always like to say, how do you think it went?
Yeah.
Because if he's like, oh, that was awesome.
Yeah.
I know.
Yeah.
And that, yeah.
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 Did you see me crank that oxygen? I cranked it right up. I didn't know you could put 15 through a nasal cannula. Yeah. And it's surprising, it's interesting like what people say sometimes, or how their impression may be like completely different than yours. And so, sometimes I have when I'm doing my student sims, sometimes I have a student or a resident with me, so you get kind of another perspective on like how it went and really like talk through it. But yeah, those kind of general like plus delta questions up front are fantastic to say, how do you think it went? Cause you might be surprised what they say.
Isn't that working?
Oh, there it goes. So how do I apply this at my shop? Noreen and I have very different experiences, very different backgrounds. I am not sim trained. I did not spend any time after residency, other than a 2-day course on debriefing that I took that was fantastic. So I think when I think about this, I think about sim, it seems very intimidating, like, oh, I don't know if I can do this. If I qualified for this, is this in my, toolbox, or is this something I can do? And my answer to that would be, yeah, I think you can. I think you can do it successfully too. I think if you have an approach and you understand your learner group, I think you can be very successful with this without necessarily having the, years of experience that go beyond. So for me, I started out with M3s, clerkship director for M3s, and I found that using Rapid Cycle was fantastic. For example, our UECOM students don't get ACLS training, and so we had one particular sim that was very ACLS derived, full arrest, and just their ability to get their hands on the life pack and actually defibrillate the patient using live energy, multiple attempts at maybe getting to do an intubation or understand the tools. And I really felt like there was you could see like a sense of pride in that group as they would kind of leave the sim center, just feeling like they were, maybe I will be a real doctor someday. So I think, depending on your group, I think it can be very different. I also found that a lot of our debriefing sessions would end up being almost a tie between like what they knew from the classroom and what clinical skills we were able to like cover or talk to them about that given day. So a lot of times they love to talk a little bit about pathophys and such things because that's what they know. And so like making that correlation, it kind of like tells them, oh, that first and second year sitting in a classroom listening to someone talk all day, it was totally worth it because it actually matters. Or being able to like help them glean out those clinical pearls that, they'll take anything at that stage. As opposed to like your M4 learners who might be a little bit different. I'm the clerkship director now. And, we have some students that kind of think they know it all. There's some that like want to prove to you how much they know. And it's interesting to see like different groups in the same day will end up in completely different locations when it comes to like where the sim ends up, where they go and where it comes down to. And I think for me personally, I love doing advocacy inquiry with this group just because I don't think you're obviously going to be able to change their entire practice in 1 month on an emergency medicine rotation, but you might be able to change the way they approach the undifferentiated patient or a very sick patient, and they're all dying to take care of sick people. At least they think they're dying to take care of sick people. And this is just a great, safe way to do it. As far as simulation in medical school, obviously, it's on the rise. It's getting bigger and bigger, and Rand created a curriculum at UEComp that we've got students quarterly coming in to do ultrasound training and sim training. That's really like taken off, and we're getting them earlier and earlier. M1 students in the ED now, hanging out, watching us, getting an idea of what's going on in the clinical realm. So it's on the rise. And as far as like the AAMC, entrustable professional activities, EPAs, if you're looking for some footing or somewhere to stand kind of with your local medical school, EPA 10 is us. This is what we do. We resuscitate folks. I'm sure nothing against our colleagues in some other fields, but this is our bread and butter. We should own this, on that level. And with our UGME students, certainly with our residents, we already do. But I think this is an area where if you want to find value in what you do at the medical school level, this is a great place to start.
Some shameless self-promotion. Our Merck group published 2 EPA 10 cases to the MedEd portal. And they're written kind of for EPA 10, and we're hoping that we can collaborate with other institutions to use those cases because we have checklists already kind of defined about recognizing abnormal vital signs and things like that. But if anybody's interested in SIM, because I agree, I think, you're not going to be able to do this on the wards for 200 students a year, right? Probably, and standardize the thing. So SIM is absolutely the right place.
It's the right place. You know what they're getting. They can leave. They're going to leave your clerkship. We have 2 weeks with them in M3, and it's always, we actually steal those 2 weeks from internal medicine. I guess they gave them to us, but they don't want to give them back. They love it, but it's always the highest rated part of their internal medicine rotation is the 2 weeks they spend with us in the ED. We do a sim with each group. It's huge. I mean, for them, it's like, holy cow, I'm actually might be a doctor someday. This actually seems real. So yeah, EPA 10, that's like our bread and butter. So conclusions, we kind of went through all the theory and case creation assessment. If there's any questions or anything we can answer for you or comments, feedback, anything like that, we'd be happy to take them up here or in the back, whatever suits you. I think for me personally, Narayana, I'll let you take a shot at that too, but for me personally, I think probably my reputation is being that of somebody who's very transparent, not always like like, oh, he's a real advocate to our students, but dude will tell you the truth, you know? And so for me, it's always like, as soon as I see that, if I see that there's like a total, you know, VQ mismatch maybe to like their ability to do and what they think they can do, I'm immediate to, not in front of the group very privately, but to say like, hey, we're a little off there. What was your kind of your feelings of how that went? Maybe like a little bit more personalized time. Maybe have them come back and do another session, whatever it may be. But I think for me personally, it's being just very transparent about my opinion of how it went, and maybe tried to circle back to understanding maybe where they're kind of missing it a little bit. And so for me, I mean, fortunately that's a rare, not a very super common thing. I wouldn't say that's like 1 out of 2 that are that way, but for those that you do have, I find that just being very transparent with them about, okay, we were pretty far off base there. You know, what were you feeling what were you thinking as the project went along there, as long as the sim was going along? Were you concerned at all about the saturations in the 60s? And sometimes if you're doing kind of an advocacy inquiry type debriefing style, you might find that they just have a really skewed view of like how to approach that patient, and you might really like get to the heart of that. You could really help them out.
Yeah, so I mean, like Andy was saying, that's exactly what I do. I do advocacy inquiry with these people. I'll just kind of stop, and I don't try to put them on the spot, but I do ask them, what their thought process is and what they recognize. And I'd be surprised that sometimes students don't recognize. Like, for instance, in the case that I just played, our student really didn't know that he could use a non-rebreather or bag. He just didn't think of it. And, sometimes those very simple things, all you have to do is acknowledge it and kind of question it, and they'll be like, oh, you can see the light bulb go off. Oh, wait a minute. Yeah, I really don't know what a non-rebreather is, and I don't know what a bag valve mask is. Maybe I should learn how to use it. And so that's happened. And there's been, I'm going to come to you 1 second, Ernesto. There have been one case of a student which was truly a very difficult case where, this person was on a separate plane altogether. I mean, you have your average students. You have some people who've got a lot of confidence, but not a lot of skill. Everybody's learned that curve. But one student who basically just didn't get it. And there was, significant problems in application, and they would do really well on paper, but they could not apply their clinical knowledge. And they needed a little bit more directed feedback, and they needed one-on-one sessions. We tried to remediate that person. We tried to do it through the medical school as well. We went back and said, hey, this is something that we need to help this person get better. And it wasn't successful. This person was not successful. But majority of the people, if you actually use advocacy inquiry approach without kind of putting them on the spot, and they're just kind of questioning in generally, inquisitive ways, so what are your thoughts? I really want to know, like, why do you think of this, not that? People will all of a sudden realize the answer themselves. And that's the beauty of debriefing, is that they will provide you with the answer and it'll come to the realization themselves. Yes?
So I love the,
advocacy.
Yeah, I'm just sure this morning, but a big part of that is the debriefing with good judgment, and a lot of the times we do our students a disservice by giving them, you did this great, you did this great also, and I think the people that progress to a 3rd or 4th year level where they can go with and be that bad are the folks that focus on the bread and not the meat. Yep. And that's because we're doing them a disservice. So I think if you focus on, like you said, wow, that was kind of terrible, right? But let's break